My name is Frida Pineda, and I will be helping facilitate the LC for today. This first session of the Learning Collaborative will be on health for all, increasing inclusion for people with disabilities. And this is presented by the National Center for Health and Public Housing. So before we keep moving forward, here are just a few housekeeping items to remind everybody that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or any concerns that you may have. Give me one moment. At this time, I'm going to enable one of our panelists here to help me admit everybody else. One moment. All right, Chantal, I just made you a co-host. Okay, thank you.
Thank you.
Yeah, and then please also raise your hand if you would like your line to be unmuted. This session is purpose of the session. We're going to have all the participants make sure that they engage in some of the questions that we're going to be providing throughout the session. So if you would like your line to be unmuted, raise your hand. This meeting is also being recorded, and the slides and the recording link will be sent to you all via email after the session. So here we have some information about the mission of the National Center for Health and Public Housing. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is also a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. And here we have, these are all the speakers for today. Again, my name is Frida Pineda, and I am the TTA manager here at NCHPH. We also, we're going to be hearing from Dr. Kevin Lombardi, who is our manager of policy research and health promotion. With us, we also have Dr. Jose Leon, who is our chief medical officer, and our communications manager, Chantal Moore, will also be helping us to facilitate today's session. And Kevin, would you like to provide your introduction?
Hi, my name is Dr. Kevin Lombardi. I'm a physician epidemiologist. I will be the center of the wheel, so to speak, for this LC. My background is a pre-medical background in history and anthropology. Before medical school, I did both my MD and my MPH at the George Washington University in DC, and training in internal medicine at Danville Regional Medical Center. My public health experience is chiefly in field operations and research. I served as executive director of Your Story International between 2011 and 2015. And we primarily focused on public health deployment in Mississippi and Haiti. My research is primarily related to medical protocol compliance and the social determinants of health. So very looking forward to meeting all of you, and I'll pass next to my colleague, Dr. Leon. Could you give us a quick introduction?
Yeah, hello everyone. I am Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And I've been working on these collaboratives for many years. And I have some experience in primary care settings, around 20 years working at the community level with community health centers. So I'm very pleased to be part of this conversation. And Chantal?
Hello, everyone. My name is Chantal Murray, and I'm the Communications Manager for the National Center for Health and Public Housing. I have around 5 years of communications experience, and I possess a bachelor's degree in mass communications and a master's degree in communication studies.
Wonderful. Thank you so much for providing your introductions. All right, so moving on forward, here we have some additional information about health centers that are close to public housing. As of 2022 Health Center UDS data, there were over 1,300 FQHCs that served to 30.5 million patients. 483 FQHCs are intermittently accessible to public housing that also serve to 6.1 million patients, and 107 public housing primary care grantees served to over 935 patients in 2022. Then just to provide some more background information about residents in public housing, this data basically describes the demographics of residents of public housing. And as it is displayed here, the 1.5 million residents demonstrate the characteristics that differentiate them from the general US population. And for an example, residents of public housing are approximately 2 times more likely to be African American, 1.5 times more likely to be Latinx, and 1.5 times more likely to be children. And residents of public housing are also disproportionately from households that are low income and female head. And now I will pass it on to Kevin Lombardi to continue with the presentation.
Okay. Well, firstly, I wanted to extend a thank you to all of you for joining us for this topic and to your service to your communities. Today, we're going to get a sort of step in the door with this topic and a look at our challenge, which is understanding the perspectives of individuals experiencing disability. The perspective that we will be using today to garner more understanding is one through a case study of an individual who's challenged with a disability in their lives. Two, a look at some recent data regarding the lives of individuals living with disabilities in public housing and HUD-assisted individuals living with disabilities as well. And 3, a review of some recent publications and resources on the topic, including a GAO report that gives us some details into the lives in the home of individuals living with physical and intellectual disabilities. Next, please. Okay, now to kind of go over some expectations for today. You can think of the format as a session as a mix between a traditional lecture and a discussion-based workshop. What we'll be doing is I will be going through the material, the case studies, the research from a lecture-based perspective, and then we'll be looking together at the discussion questions and the clinical cases in particular. These questions are designed to take advantage of the diversity of experience, diversity of professional background that we have in these sessions. I like to think of it as the best resource that TTA sessions really have is their front row seats to something with your colleagues. The folks that have joined us today range from administrative to clinical to social support roles. They range from entry-level employees to CEOs. They range from people who do not see patients to those who see patients constantly. The diversity of those perspectives is the primary asset that we're all taking away from this. And I say that to say, when we have our discussion questions and when we are sitting together in our discussion and breakout rooms, take the time to invest in your colleagues because they're where really the color will come from this learning collaborative. So these will be in the guise of interdisciplinary discussions. And finally, the discussion session format is designed to elicit the main themes. So we'll be keeping ourselves focused on the learning objectives throughout this and our subsequent sessions. Next, please. So some details on our research and resources. In the bottom left, I will have the links to whatever resources that we happen to be focusing on for those slides. This is designed to be a consulting document type slide. So links are always at the bottom left in sort of a standardized way. And all of our research and resources have gone through a significant literature review from our office to ensure that they're right for you. So that is the system, and you'll all be given access to our landing page and to our resource slides, so you can use them as deeply or as you would like. Next, please. So let's start by going through some of the details regarding what HUD considers disability. So what is and what is not a disability from a philosophical sense will not be how we'll be discussing the conditions that lead to individuals having disabilities. We'll be focusing on the HUD disability classifications. So HUD has 6 main ways that it defines disabilities, and I just wanted to briefly go through some conditions that would be in those categories as we start to piece together the lives of people with disability in public and assisted housing. So HUD defines sensory disabilities as deficits in sensory feeling, blindness, deafness, sensory processing disorder. These are all under the sensory category. Physical disabilities are defined as things similar to spinal cord injury, muscular dystrophy, cerebral palsy, morbid or supermorbid obesity can also be classified as a physical disability. Mental disabilities are disproportionately present in the public housing and HUD-assisted population. In particular, schizophrenia and bipolar disorder are very common in both populations. Next, please. HUD also designates deficits of self-care or ability to self-care as a disability as well. People with self-care disabilities have severe physical and intellectual impairments that lead to deficits in their daily living and maintenance of their daily activities of living. Other HUD disability classifications include go outside of the home disabilities, such as patients with certain types of anxiety disorders and employment disorders, where the patient's physical or intellectual disability impairs their ability to find and maintain employment. Next, please. So let's look at the numbers of how many people who live in public housing and who are HUD assisted. What's the proportion of disabilities? And these numbers are for both physical and intellectual disabilities. So for the HUD assisted population, which is about 4.4 million people across the country, about 42% report having a disability. When you compare that to the general US population, that's about twice the rate of disability. Next slide, please. In addition to a disproportionate number of folks with intellectual and disabilities and mental disabilities being as part of the HUD assisted and resident public housing population, it's important to realize how many folks with disability who do qualify for this funding, who do not get this funding. If we look here, this is from a GAO report on the HUD-assisted population. Income eligible households that received and did not receive HUD rental assistance by income and disability status, we see sort of the disparity between those who do qualify for those resources and those who actually are able to secure those resources. Next slide, please. And here's where our individuals with disability are living in terms of public and assisted housing. We see the housing choice vouchers has the largest percent of that population at 45. Project-based rental assistance is close behind with 36%, and public housing being 19% of the population. Next, please. Okay, so we're going to transition over to a case study. And I'm going to go ahead and read the case study, and then we'll be going out into 4 breakout rooms to discuss questions regarding the case and our thoughts regarding the patient. Mr. Jones is a 57-year-old man who presents for a wellness exam. He has a past medical history of type 2 diabetes and hypertension. Patient has a behavioral health history of major depressive disorder, post-traumatic stress disorder, generalized anxiety disorder, and tobacco use disorder. Mr. Jones is a combat veteran. Your health center has a large veteran population and is in the suburban area of a medium-sized city. Mr. Jones identifies as African American. The patient undergoes a standard intake, including vitals and an SDOH screener, and the results are follows. Blood pressure 178/98, heart rate 92, respirations 18. A review of Mr. Jones' medical records indicates that in 2018, the date of his last appointment, he had a blood pressure of 138/98, substantially lower, heart rate of 60, also lower, and respirations the same at 18. You can see from his reports that he had a hemoglobin A1C of 7.0. He had a pan-negative drug screen, and his prescribed medications included medications for diabetes, hypertension, and his anxiety and depression. Next slide, please. Now, here's the first page of the SDOH screener that Mr. Jones did during his intake. In the past 2 months, did you or others you live with eat smaller meals or skip meals because you didn't have money for food? He puts a yes. Are you homeless or worried that you might be in the future? He puts a yes. Do you have trouble paying for your utilities? Yes. Trouble paying for a ride? Yes. Do you need daycare? No. Next slide, please. Are you unemployed? Yes. Help finding another job? Yes. Do you need help getting more education? Puts a no. Are you concerned about someone in your house using drugs or alcohol? He puts yes. Regarding safety and if anyone is threatening or abusing the patient? No for both. Okay. So let's go to the next slide. Okay, so Mr. Jones is treated by his provider, who is also a combat veteran. Upon physical examination, Mr. Jones is noted to be withdrawn and exhibit closed body language. His responses are terse, and he seems irritated. His physical examination is positive for 1+ pitting edema and darkened skin around his neck and groin area. New results are positive for an A1C of 8.2. When questioned regarding the result of his SDOH screener, Mr. Jones reveals the following information. 1, Mr. Jones worked as a construction foreman until 6 months ago when he was laid off. His unemployment insurance ran out 3 months ago. He's behind on his utility and his car is not operable. He uses Uber and walks for transportation. Mr. Jones reports more frequent panic attacks in the past 6 months. He's having them 2 times per week versus 1 time per week a year ago. Okay, Mr. Jones is single, does not have any family in the area. And he has been taking a half dose of his prescription medications because he can no longer afford the medication. Mr. Jones is asked if he is interested in treatment for his behavioral health conditions. or SDOH issues, but he avoids answering the question. When questioned again, he notes he prefers to deal with his private life by himself. When asked why, he notes that in the past he had difficulty connecting with his providers and that he felt judged. Next slide, please. Okay, so here are our questions. The questions are two. What is your assessment of Mr. Jones's clinical condition? Is it getting worse or better? Why? And how could a patient like Mr. Jones be encouraged to seek supportive services? Okay, so we are going to break into breakout rooms for 7 minutes. Each of us will get one of the 4 groups, and we will go through these questions together. And each group just be ready to present an answer and have someone who is willing to do the presenting for you. So let's go ahead and break into those groups for, let's shoot for 7 minutes.
So we're still waiting for the other participants to come back to the main session. Hi, everyone. Hopefully we all had a...
Takes us right back. Sorry, Fide, go for it.
No worries. I mean, I assume we were having some really good conversations in these breakout sessions, which is great. So I can start by providing just a brief summary about what we discussed in our group in room 4. So definitely we mentioned that that Mr. Jones may need a medication adjustment and why, and also address why he is getting worse with his condition. And also definitely assess like the different ways and how we can pass on more of his information, more information and resources to Mr. Jones. And also here, and how, and address, and also see which of his issues that he is facing should be addressed first, such as like his diabetes condition or his medication and things like that. So would anybody else like to help me elaborate a little bit more on their responses for this session?
So am I hearing, so what am I hearing in terms of, is this patient getting better or not? What's the direction here? What's the graph?
So
We say no, that he's getting worse.
Yeah. So this guy seems like it's getting worse, and it seems like it could be happening pretty quickly too. It's like we've had a lot of STOH issues that jumped up in this patient's life very quickly. So yeah, I hear that. The second part of the question, how do we get a patient like this to seek supportive services? One that's talking to us like this, who is as described in the stage. Do you guys have an answer for that?
Hey, Kevin, can we go through the responses from the 4 groups to see whether we can capture more?
Yeah, sure.
From the first and the second. We had a really good discussion in group 2. And a member of the group took notes. So please, if you can chime in on these 2 questions.
Yeah, so we also agreed that that his mental as well as physical health is on the decline, and that those issues do need to be addressed. One of the group members suggested that with him being a veteran, that maybe he could speak to an organization who has veterans who could serve him. He may be more trusting of a veteran over a civilian. So she thought that that would be a good strategy. And I think she's also a veteran. So thought that was really good. I would have never thought that. And also someone suggested as a way to encourage him to seek support is because he seemed like he was okay with filling out that form. So maybe having him fill out more forms as opposed to verbally answering questions may be a little bit more comfortable for him. We also had the doctor suggest motivational interviewing as a technique to get him to kind of open up a little bit more.
So I'm hearing some really interesting responses here. And I'll address them all in the group at the end, but I do love the veteran versus civilian service. And I do like the power of the form, that at times it can help people feel more comfortable in giving that information. I think we'll go next to our next group. I think which one is that? Let's use mine. I'm not sure if there are numbers here. Was there someone who wanted to share our responses?
I can share our responses.
Thank you.
So I think we we agreed that Mr. Jones is not getting better. He's definitely getting worse. I think one of the tactics that we talked about was to use the combat veteran relationship that the current provider has to form that connection, right? And to give him that kind of sense of, I get where you're coming from. You know, a lot of times veterans, they might not have family, like he doesn't have family in the immediate area, but sometimes other veterans are family in that community. And so to try to leverage him, like someone else said, in with some veteran services. It also occurs to me in my occupational therapy background that he has a total loss of all his occupational roles. You know, he lost his job recently, which probably is paying a factor on him not being able to pay for his utilities, getting behind in his vehicle, and not being able to afford medications. So, you know, that could be not the only root, but a major root problem of his whole situation. So getting him connected potentially with some employment services that would empower him to be independent.
Yeah, so there's a lot of things there that speak to the complexity of being an individual with a disability and being an individual with a history of military service. It to a certain extent, when I hear how you're describing that, I see it as in a way it's very similar to how we address cultural competency as well. These are individuals who have a very specific language that they speak and very specific communication needs. So I know with having done rotations in veteran military centers myself, that having someone access to providers with military history, it gives you an ability to reach these patients in a way that may be otherwise difficult. And I think we have one more group.
Yes, so in group one, and you all can feel free to chime in. For the first question about Mr. Jones's clinical condition, we decided that it was getting worse. If you take it into a more layered concept here, the SDOH is the root of the problem. And then that ties into his mental health, which affects his physical health. And since his circumstances have recently changed financially and employment-wise, that is exacerbating his physical and his mental health. Some things that we discussed for the second question about how he can be encouraged to seek supportive services is see if he could have a case manager or a community health worker, reach out to the local Veterans Affairs office. And those are some suggestions to help encourage him to seek supportive services.
Yeah, thank you for that. So let's sum this up and look at some of these, and I'll start with the ones that you mentioned, your group, Chantel, that sort of link to everything. Is one, the SDOH, how intricately it's connected to this patient's clinical case, and how exacerbations in his SDOH situation have corresponded with exacerbations in his medical care. And when you look at the details here, the taking the medications less frequently and so forth, it tells you why. So number two is the importance of addressing the patient's military service, given it's a large part of this patient's history and identity, and having a CHW, a social worker, or other professional that has a history of medical of military service can sometimes be very helpful. Using the combat veteran relationship of the individual in the exam room and the individual doing the exam, and the difficulty of seeking services for many patients with military background. Let's go and look at the case and point these things out. Okay, next, please. Okay, so we see this patient's clinical history. He's got type 2 diabetes, hypertension, Behavioral health history is complex with major depressive disorder, PTSD, and generalized anxiety disorder, tobacco use disorder. And it mentions he's a combat veteran. Okay, let's look at the vitals. Okay, BP 178/98, heart rate 92. He's quite a bit higher than he was in 2018. And he's experiencing a pretty significant change in terms of his blood pressure and heart rate. So already making me a little suspicious. I've got some baseline data here that I'm gonna want to follow up though. Here, see, I see an A1C of 7.0. I see he takes 3 different medications for his diabetes, for his hypertension, and for his depression. Okay, let's look at my exam. Next. Okay, during intake, we have our SDOH screener. Next, we have a variety of really troubling things that this individual is going through, a variety of challenges. Okay, next, please. Okay, so with these screeners, and many use the Prepare screener, I chose to put the Well RX because I think it's more well designed for alteration. It linked to the resource in the bottom of the left, you can see that. But the SDOH screener tells us the details of the services he may need referral to. So that's what I'm doing when I'm kind of taking a look at this. Next, please. And here's kind of the data we have, is we have a variety of SDOH issues that are happening quickly and are happening now. With unemployment, his employment insurance ran off. So income has gone from full-time income to functionally zero in 6 months. He's starting to lose access to services and transportation, and is experiencing panic attacks now 2 times per week. Panic attacks are extremely debilitating, in particular for individuals when they're having them multiple times in a week. It makes it very difficult to continue to stay employed or to find employment. And we have the medications. We're losing about half of our medications a day because he's trying to spread the pills out. And oftentimes when individuals aren't sure they're going to make it to the next time the pills need to get bought, this is just what happens. And we see a predictable exacerbation of his blood pressure and his depression and anxiety symptoms because of that. And just because cases like this are never easy, this individual, he doesn't really want to talk about it. So he's exhibiting closed body language, terse answers. It's like, for individuals like this, encouraging them to get services is kind of difficult. It's like herding cats. And the way to do that is kind of what we addressed, but this is a patient who's going to need continuity of care. So we're going to look over some data and then come back to Mr. Jones. Not sure if that's going to be towards the end of today's session or next time, but our next step will be to follow Mr. Jones in the supportive care clinic as he's working with the CHW via telehealth. Next slide, please. Okay, so now we're going to look at some data about the individuals that live in public housing and HUD-assisted families, in terms of what their disability status is compared to the general population. This is a study that was done by my department here at NCHPH. And just a little bit on how to read this table. We get our p-values, our main takeaway as far as statistical significance, and our 95% confidence intervals as well, right here on the side. Next slide. And we've got 3 groups that we're looking at. What I did in this study was compared HUD-assisted patients to folks that do not live in assisted housing, and residents of public housing to folks that do not live in assisted housing. So we can see the difference in how they experience daily life. Next. So what we find here is that for our residents of public housing and HUD-assisted, they have about a 10 to 13% chance of being deaf or blind, but that's not substantially different than the general population. Next slide. But when we get to different metrics to describe physical disability, that's much different. If we look at a difficulty with self-care, such as washing and dressing, patients from that live in public housing are nearly twice as much as likely to experience that. Patients that are HUD assisted are nearly twice as much to experience that as well. We look with difficulty eating, and that's with the mechanics of eating. And we compared our residents of public housing, we see they're nearly 3 times as likely to have difficulty with eating on a daily basis. Next slide. And here are our sort of focus points here. Do you have any difficulty with self-care, such as washing all over or dressing? This is for all patients at FQHCs. And with our folks that live in non-supportive housing, 10.9% were experiencing that. Our rate for HUD-assisted and public housing residents is about twice as much. Next slide, please. And difficulty with eating, about 3 times as much. Residents of public housing were nearly 3 times as likely to report a difficulty with eating than the general population. Next slide. Difficulty getting out of bed and chairs. The residents of public housing and HUD-assisted patients were about twice as likely to report difficulty getting out of bed or out of chairs. Next slide. Here we see the magnitude of these differences again. When we look at during the past 30 days, how often did you feel that everything was an effort? And this is a metric of depression. And we can see that that is significantly higher for a HUD-assisted and public housing patients. Next slide, please. And some more details on this. Well, the main takeaway being, for those of you who take care of residents of public housing, for those of you who take care of HUD-assisted families and individuals who are SIDE-assisted, know that these groups are uniquely, are much more likely to have physical disability than those that do not. Know that these populations are very scattered, so you may not know that you see residents of public housing, but they are there. Having a screen, Prepare WellRx or a similar SDOH screen can help you to better identify these patients, so you can give them access to SDOH services that might be helpful for them. So let's move on to our next slide, please. And let's look at likelihood of experiencing falls. Because we all hope for our residents of public housing, for our elderly adults, that they live in safe places where they aren't going to trip and hurt themselves. But how many falls related to led to an injury? We can see that our HUD-assisted families are more likely to have injuries at home than folks that are not living in assisted housing. And next slide, please. So we are going to stop with the case here, but what we'll be doing next week is taking a look at Mr. Jones as he meets with his CHW via telehealth. And Fide, I'm going to ask you to jump ahead to a slide. Can I give you the number? Fide, if you could go to slide 44, please.
44.
And one more, please. Yeah, and past that as well. One more. Okay. So we're going to wrap up by looking over some more details from the GAO report we looked at earlier regarding HUD-assisted individuals and residents of public housing. And the important takeaway here is how this housing is as far as being up to date on mobility and access. Next slide, please. So examples of structural modifications that folks really need in order to have healthy access to their building. And this speaks to the benefit of both doing home visits and telehealth and being able to access to the patient's built environment. Research consistently shows that for HUD-assisted individuals and residents of public housing, they increasingly do not have access to these modifications. But small modifications throughout the house can lead to significant increase in risks of severe bodily harm or injury. Examples being lever-style doorknobs, bathroom grab bars, widened doorways. The importance of the home check and having staff or referral systems that are that allow the ability to do the home check is very important here. It disproportionately, residents of public housing and HUD-assisted individuals are more likely to be are older adults. Being able to when you identify an individual who is older and living alone, or who has a disability who is living alone, and you suspect that a home visit might be valuable in terms of helping make their environment safer, being able to know that those populations, in particular HUD and residents of public housing, are more likely to not have these structural modifications than the general population. Next, please. And some more of our HUD numbers on HUD-supported residents with disability. So this is proportion of HUD-assisted households with the new mobility device user that reported a no-step energy or an in-unit accessibility features. And what we see is 30%, 33% don't have those necessary structural modifications. Next, please. Here we see proportion of HUD-assisted households with a mobility device user that reported a no-step entry in 2019. We see that 28% do not have that too. So for individuals living in public housing and HUD-assisted individuals, the number of folks that do not have access to the accessibility features necessary to get into their homes is a big surprise. And it isn't something that you should just assume based on their status. Being able to access information about this through either an interview or a home survey is an important way of linking those individuals to services. So we will stop the regularly scheduled part of this now. Fide, can you go to the questions? Okay, so we have a few moments for a Q&A. I will stay later if folks would like to chat about material, promising practices, or anything of the like. And I guess at this point, we will open the floor.
All right, so in the meantime, while we have any questions that are coming up through the line, I'd like to remind everybody that we have our upcoming sessions next week on the 4th, and then we also have it on the following Monday on the 11th and on the 18th. So we look forward to seeing you all in our next sessions. And also please complete our post-evaluation survey at the end of the session. This will help us make any improvements as we continue completing the Learning Collaborative.
I have a quick question, if possible. On the question about difficulty eating, does that also include like food deserts and availability of food, or is that strictly, you know, the ability to actually eat a meal itself?
So that particular piece of data is the ability to physically eat a meal. So individuals that have difficulty either for a variety of different physical disabilities or intellectual disabilities, actually physically eating.
Okay. Thank
But
you.
you do emphasize an important point, is that the food deserts are a huge issue for residents of public housing and our assisted adult. And my memory from the same study was that our data was about 30% are having difficulty with access to food and intermittent hunger. And we'll go more into detail of sort of the various ways to link people to the SDOH services. But a CHW or an individual who performs the roles of CHW is a great person to have in that role, in that place. In particular, if you're able to do an SDOH screener before your clinic exams as part of sort of a standard intake, you'll be able to network folks to services more efficiently and be able to tailor those services to what they really need. And, you know, for those of us who are at primary care offices, that's an important part of our role in the community. And it's an important part for many of our reimbursement strategies to make sure our community health is as good as it can be. Any other questions? All right, folks. Well, thank you so much for your time and for your continued commitment to serving your own communities. It was great to hear some of the details of your perspectives and how to teach, how to take care of these complicated patients. So I really appreciate that, and I'm looking forward to hearing some more of the professional acumen we have in this group. So thank you all for your time. And looking forward to seeing you next week. Fide, I'll pass the close off to you.
Thank you. Thank you so much, everyone. Yeah. And here is our contact information. If you have any, my apologies. If you have any other questions or follow-up questions that you would like to send to us via email as well until next week.
Thank you.
Thank you. Have a wonderful rest of your week, and we look forward to seeing you in our next session.
Bye.
Bye.